Thank you very much. So after this very beautiful presentation by Dr. Praz, we'll move on to echocardiographic imaging before and during transcatheter valve replacement on the tricuspid side. So we all know that the problem of tricuspid regurgitation that is often undertreated, and it impacts many of our patients in a significant way. And many of our patients come in symptomatic and with a great host of symptoms and problems. Now that we have the CE mark approved evoke valve for transcatheter valve replacement, that offers a promise to solve this major problem for many of our patients. As we all know, the evoke valve is a self-expanding valve made of nitinol with bovine pericardial leaflets, 28 French delivery system from the transfemoral transvenous approach, and it comes in 4 sizes, from 44 up to 56 millimeters. We saw very well before that the importance of assessing the tricuspid valve carefully for its anatomic characteristics, and up to now, the only available modality we had was edge-to-edge repair. So we needed to understand which patients are favorable for edge-to-edge repair, intermediate or unfavorable from an anatomical perspective. And we know that for many of our patients with presented for edge-to-edge repair, they are deemed to be unsuitable mainly because of large anatomical reasons, large annulus size, RA and basal RV dilatation, significant tethering of the leaflets, and major coaptation gaps. And we know also that in clinical practice, many of our patients that we do edge-to-edge repair are sort of intermediate anatomies that we know that may not fare very well and to have optimal result, but we have to do them to get at least a reduction of the tricuspid regurgitation and alleviate the symptoms. In the area of tricuspid valve replacement now, we have to be more careful in our patient selection, and we have to go into this by considering that if a patient is not primed anatomically suitable for edge-to-edge repair, then a suboptimal result with edge-to-edge repair may close the way for the therapeutic option of transcatheter valve replacement. So we have to consider that very carefully nowadays. Now, evoke valve can be applied in multiple types of, all phenotypes of tricuspid regurgitation: the ventricular functional phenotype, the atrial functional, the primary tricuspid regurgitation, and very importantly also the pacemaker-induced tricuspid regurgitation. It's very important, as highlighted before, to understand very well the function of the right ventricle. We should use all available modalities. The TAPSI, RVSDDI are the basic ones, but not they don't tell the whole story. We have to go with free wall strain of the right ventricle, fractional area change, and very importantly, right ventricular ejection fraction measured by 3D echocardiography. And with that, we can have an idea whether our patient is mild, moderate, or severe RV dysfunction. So here's an example of the available modalities that we have to use beforehand to understand as much as possible the functionality of the right ventricle. In terms of our screening echocardiogram for our patients, we apply the same tools that we applied in all our patients with tricuspid regurgitation, primarily transesophageal echocardiography with biplane imaging from a mid or low esophageal position. It gives us a very nice understanding of the tricuspid valve, the coaptation gaps. We can scan the valve from anterior to posterior and have a very good idea where the coaptation jets are and what the underlying anatomy of the leaflets is. Also, the transgastric views are very, very important because they give us a very nice understanding of the number of valve leaflets, the distribution of the cords, the presence and location of the coaptation gaps, and it's just a wealth of information with this single view that we have to always do in these patients to understand what's going on. Very importantly, especially in the area of valve replacement, is the use of multiplanar reconstructions from a 3D data sets. 3D data sets can be obtained from mid-esophageal, low esophageal positions or transgastric positions. Very important that we can do that from all positions. And with that, we can, using the landmark of the aortic valve, understand our location and what is septal, what is anterior, what is posterior, and very importantly, have an idea where the coaptation gaps are, and so on. More importantly is the use of multiplanar reconstruction in our procedural guidance, where we take a 3D image data set and we analyze it into a commissural, long axis, and short axis, all in one image, all in one frame image, all available options to see and understand our position, our trajectories, and all that we need to understand. So again, we are able to say what is posterior, what is anterior based on this commissural view, what is septal, what is lateral on this view, and in the short axis transgastric view, which is clocked at 5 o'clock with the aortic valve at 5 o'clock, we have septal, anterior, and posterior. So with that, it's very important to use that because especially for orthotopic valve replacement, we use that heavily. In terms of annular sizing considerations for the evoke valve, primarily the choice of valve will be done by CT, with the echocardiogram, however, giving us an initial idea about the perimeter of the annulus of the tricuspid valve and whether a patient may be eligible or not. Here's an example of a patient with a torrential tricuspid regurgitation with a rheumatic tricuspid valve. And the CT perimeter-derived numbers gave us that this patient would be suitable for a 56 millimeter valve. Again, on screening as well as on the day of the procedure, we'll have to reassess the annulus area because if that has changed because of the patient being over-diuresed, then the choice of valve prosthesis that we've chosen may be different. The first step of the transcatheter tricuspid valve replacement is to get a stiff wire at the RV apex, and we want to get it behind the anterior papillary muscle to as close to the apex as possible because that will be our rail on which the implant delivery system will come up upon. So once we have the the wire at the RV apex, then the next step is to advance the delivery system into the tricuspid valve, as we can see here. By doing our multiplanar reconstructions, we can assess our position and trajectory, which is very important. We have the possibility of doing changes in our septal to lateral position with our secondary knob on the delivery system. With that, we have to have it optimized as possible. Once we have this position optimized, then the next question comes up is how deep are we in the right ventricle with the end of the capsule of the device. Sometimes that is not always easy to see. Sometimes fusion can help us understand our depth of our implant, of how deep we are below the valve. Here, the imaging was not very optimal. The next thing we can try and help us out is do a little bit of a capsule retraction to create this capsule gap. At the end of this of the delivery system, we have this retraction of the capsule, just enough to create a small gap that we can see. And here we could actually visualize this gap. This is transthoracic imaging to visualize the gap and understand how deep we are in the below the tricuspid valve annulus plane. However, this is a pacemaker wire that goes into the coronary sinus. The next point at this point is because we have to do a timeout at this point, because once we open the capsule further, it's a point of no return. We have to deploy the valve. So at this point, we have to understand our depth that is adequate, that we need to understand our position is central to the leaflet coaptation, our trajectories are coaxial, and we have enough good imaging to proceed. And once we proceed, the next step would be to do a further retraction of the capsule and exposure of the 9 anchors of this of the valve. Shortly thereafter, we go to the anchors more exposed at about 90 degrees. So at this point, it's very important again to understand our depth below the tricuspid valve annulus and the tricuspid valve leaflets. And with that, we have to go back on our NPR, and we try to do a spinning where we rotate the planes in this right lower image, and we look at the corresponding image above, and we look at the position of the leaflets over each and every anchor of our device. We have to have the leaflets going over our anchors and freely in systole and diastole. So once
is there any specific measurement on echo How much, for example?
We have to see them all moving freely. We don't want them to be impinged in any way. We have to have our device at this point to be below the leaflets by at least half a centimeter, if you want to give you a number. The next step of this is to do the further retraction of the capsule, and now the anchors come towards the atrium, and that's what we call the atrial flip of the anchors. Again, this is a very important step that we want to assess that all the anchors are below the leaflets in systole and diastole. For instance, you can see here in this view that this leaflet is not over the anchor. The anchor is above the leaflet, so we have to advance our depth a little bit and again do our spinning maneuver to assess that all the leaflets move freely above our anchors. So the next step after, so once we have that, then we can also use our biplane imaging. If there's anchors that we haven't clearly visualized in our MPR, we can go back and see if these were an anterior anchor, for instance. We can see it down here very nicely that the leaflet goes over it and it's moving freely above it. That it's either engaged or ready to be engaged with the anchor. So the next step is to do what we call ventricular expansion. As you see, retracting the capsule widens the device and progressively will widen to come and engage the annulus. Again, very important at this stage to reassess all the anchors, all 9 anchors that are moving above the anchors and they're freely moving and not being pinched in any way. And again, we're going to do our spinning, and from you can see here that we spin the green line, and we look at this image here to see that all anchors are nicely inserted into the device. Subsequently, we do our further ventricular expansion. Again, this brings the anchors even closer to the annulus of the tricuspid valve. At this point, we want to confirm leaflet engagement, and we can also do some tilting maneuvers, septal, lateral, posterior, and anterior. And once we have that, then we move on to atrial expansion and release of the valve. And so this is the final position of the valve with the final appearance. We may have a trivial central jet. We look for any paravalvular leaks, trivial, if any, may be noted. Again, we assess immediately also the functionality of the right ventricle because we want to make sure that we don't have any significant RV dysfunction. Some studies have shown that long-term, in the short term, we may have a drop in the ejection fraction of the right ventricle. However, this is offset by an improvement in the stroke volume of the right and the left ventricle. And what we see usually is a drop in the right ventricular and diastolic volumes. With that, I would like to summarize with the fact that the valve replacement with the EVOQUE valve now offers patients complete resolution of severe tricuspid regurgitation with, as we saw before. The CT will determine the choice of valve size. Intraoperative guidance by 3D echocardiography and multiplanar reconstruction is critical to enhance procedural flow and success of the procedure. Learning curve is expected. However, one will see that TTVR procedures may be more predictable as compared to the edge-to-edge repair procedures. Thank you very much.
Thank you, Dr. Chrissoheris, for the excellent presentation. Is there any questions from the audience?
Congratulations again, Dr. Chrissoheris. You pointed out and you demonstrated very nicely how image quality is very important for the success procedure. And I was wondering, sometimes it's challenging to image the tricuspid valve, not only because of the anterior location, but sometimes the horizontal axis of the valve makes taking pictures more difficult. And I was wondering whether in more complex cases, like you had patients with previous surgeries and prostheses that have significant acoustic shadowing, plus with difficult imaging modality, what would you do? Would you consider adding to your toolkit, for example, 2D or 3D eyes? Would you do pre-planning surgery? What's your point?
Yeah, we've had a few cases that were actually very challenging indeed. What we learned how to do is how to do MPR from transgastric views, something that we have not been exposed to, but it's something that we can easily learn to do. Transgastric offers a direct view of to the tricuspid valve. And if you have decent transgastric views, you can really guide the whole procedure with MPR from transgastric views. Now, we haven't had experience with 3D eyes. I know some centers have tried to use it, but it's an alternative, obviously, method for imaging in very difficult cases. But I think if in one way or the other you can find your image to do your procedure. And again, some of these procedures, this procedure might have been very, very difficult image-wise for edge-to-edge repair. However, for, I think, valve replacement is a little bit more forgiving in terms of its imaging.
Is Velasys online or not, I think? Yes? He is now? No. Okay. He's not, okay. Now we should maybe move on to other. Thank you.